I'll get started, okay? So just by way of introduction, my name is Rowan Silva. I'm a practicing ophthalmologist specializing in vitreoretinal surgery. My background is I did my undergraduate at Harvard, graduated in 2002, got a master's from Cambridge University, and then did my med school at Stanford University over in California. Did my residency in ophthalmology, eye surgery, the Boston Palmer Eye Institute down in Miami, Florida. Then did my fellowship back at Stanford, where I stayed on as a professor for 7 years before moving out here earlier this year. Okay, so I'm currently an associate at the Florida Retina Institute, based in Orlando with offices throughout Volusia County, including Daytona. And I'm here in Daytona Beach on Fridays. So the Florida Retina Institute, FRI, I'm here on Fridays. Easy to remember. I maintain my academic position at Stanford University, and I continue to fly back every few months and pursue the research that I started on mainly developing an artificial retina. I get to work with some pretty cool engineers in the Bay Area, and I've been doing that for 5 years now, and we'll continue to do it, I think, probably for the next few years. So getting right into it, so I thought what we would do is the eye is a very special structure, all right? So because of that, I thought I would start with some basics about the eye and then move on to how diabetes actually affects the eye. You can't really understand the pathology of the eye without understanding the basic anatomy of the eye and really how it works from the basic physiology. So in terms of the basics, everybody recognizes what the eye looks like when looking at an en face, picture of somebody. There's the iris, which is the colored portion of the eye. There's the sclera, which is the white portion of the eye, and there's the pupil right in the middle. So if you cut the eye in half and look at it as a sagittal section, or if you're looking at it from the side, what you actually see is the eye is really best understood as layers. So the front surface of the eye is called a cornea, okay? And it's a clear layer that allows light to pass through it. And when people talk about LASIK, for example, they're talking about really resurfacing the front of the eye, okay? So light, as it continues from the front of the eye and goes all the way to the back, it gets focused, mainly by the cornea, also by a little lens inside of the eye, and it lands on this back yellow structure called the retina. The retina is actually the most important part of the visual system. It's actually part of the central nervous system. It's part of the brain. Okay, so in order for you to see well, all these structures have to allow light to pass in, but most importantly, the retina has to actually work really, really well. So again, to kind of emphasize this idea of the eye being layers, this is what we actually see anatomically. The retina itself is the layer of wallpaper on the inside of the eye. Underneath it is a vascular layer, and then the sclera is on the layer above that. The middle of the eye is actually relatively hollow with a clear gel called the vitreous, which is mostly water. That's the majority volume of your eye. Okay, so the most important structures, again, are the wallpapers and the walls of the eye. So moving on, if you were to dissect the retina out, I'm not going to go into too much detail, but just know that the retina has many different layers to it. Okay, when you hear about rods and cones, people are talking about the very deepest layer of the retina. The eye has a really weird, kind of anatomy. Light actually comes in, it travels through the entire thickness of the retina, lands on the rods and cones, and then that signal is then transmitted back up through the retina. Actually, the light goes in, lands on the cells in the very deepest portion of the retina. That signal is then transmitted forward, comes out of the eye via the optic nerve, goes to the brain. That's how you see. Okay, so that's the basic function of the retina. This is what it looks like. So when we look into a person's eye, this is what we as ophthalmologists see. Okay, we see this optic nerve in the middle. We see these blood vessels around, and it's large, relatively vascular structure of the retina. Believe it or not, the most important part of the retina is this very central portion. This is called the macula. When you talk about macular degeneration, people are talking about aging changes which occur in the very center portion of your vision. When you talk about actually seeing well, 20/20 vision, people are actually only talking about this very small little layer here in the center of your eye. You can only see clearly with this portion. The remaining parts of your retina, for anatomic and physiologic reasons, cannot actually see clearly. When you want to see something clearly, you look straight at it. That corresponds to putting that image on the very back center portion of your eye and your macula. Okay? Moving forward, a little zoomed in image of the macula. What you see is the optic nerve, some blood vessels, and again, the very central portion of the macula is called the fovea. It's that colored portion in the middle. This is a normal looking retina. This is what we like to see when we look into people's eyes. We have really two main ways of looking at the retina that I'll get into. I'm going to briefly just touch on them because you may actually get these tests if you go and see one of us and have your eyes examined. The first is called the Fluorescent Angiogram. And it's particularly relevant to diabetes. Diabetes is really a disease of blood vessels and blood flow. Okay? Throughout your entire body, many of the complications occur because of the blood vessels in your eye. So it's really useful to have a test where we can actually look at the blood flow in the back of your eye. This is a Fluorescent Angiogram, and what we do is we inject a little bit of orange dye into your arm, your hand, or usually your cubital fossa right around your elbow. We inject this dye and then we take serial photographs. The dye goes into your bloodstream and it shows us how blood is flowing through the back of people's eyes. This is an example of a normal angiogram. we take pictures relatively quickly after patients have the dye injected, we start to see it fill up the arteries in a patient's eye. Okay, as time goes on, it begins to fill in the veins, and we see a nice normal circulatory pattern in the back of the retina. Okay, has anybody had one of these done before? You have. Okay, great. Pretty painless, right? The only thing we sometimes worry about is very rarely something like 4 patients in a million, so 1 in 250,000 will develop an allergic reaction. Usually it's relatively mild, we can give them benefit, but that's really the only risk. It does not have any consequences for your kidneys like some other dye tests do, and it's a relatively safe test. Again, the other benefit is you can actually see with very fine detail the very small blood vessels, the microcapillaries that we have in the back of the eye, which are really, really important for vision. These are the blood vessels that supply, again, the very central portion of your retina, and therefore confer a very, very high level visual acuity for people. Okay, the other thing that we use is an OCT. I'm not going to really get into the physics of how this works, but effectively what you're doing is you're using light to image the back of the eye. The retina, as I showed you, has pretty extensive and very, very fine anatomy, and it's really useful to have a test looking at the microanatomy of the retina. Until about 10, 15 years ago really, we had no way to do that. We would have to simply look or take a photograph. But now we have a way to look at it with very high, very fine acuity, actually. So when we look at an actual anatomical histological section of the retina, what we see is if we were to take a little histology, if we were to remove a patient's eye, cut it right down the middle and look at what the retina looks like, you'd see these layers, right? These different layers of cells. The only way to get this image, again, before 15 years ago, was to actually take a patient's eye out of their body and look at it, which of course we don't want to do, right? So what we can do with OCT is we can get that same sort of image, that same level of clarity by doing an OCT image in about 2 to 3 seconds, okay? So using the advanced technology, we have a pretty good idea of what's going on anatomically with patients' retinas using this new technology. And you will almost certainly get this if you see any eye doctor. All right, so that's the eye basics. So any questions to begin with there? No, okay, so now we'll go into diabetes, right? So as I mentioned before, diabetes is kind of an epidemic that's coming. I mean, right now, the number that I've seen is something like 500 million people in the world and 35 million people in the United States are affected by diabetes. The overwhelming majority, something like 90% of it, is type 2 diabetes, okay? Which, as you know, the risk factors as you get older are increased weight, poor diet, and poor exercise. All the changes which occur with diabetic retinopathy, diabetic nephropathy, diabetic encephalopathy, people who have issues with mentation and such, are really due to microvasculature. There are problems in the smallest blood vessels in your eye. The reason is diabetes is a disease, really, where there's excess glucose in patients' blood. When that happens, there is damage to the blood vessels in the eye, and this has many different manifestations. But one of the earliest places we see it is in the eye, okay? And there's really 3 different manifestations of diabetes in patients' eyes. The first is diabetic retinopathy, which I'm going to spend the rest of the talk discussing. The second are cataracts. I showed you in the that first slide, right, in terms of the anatomy of the eye, what the eye looks like. Cataracts simply mean that the lens in a patient's eye is getting more opaque. The number 1 risk factor for this is getting older. It's thought that a lifetime exposure to the sun naturally causes our eyes to age and naturally causes these lenses to become more opaque. Diabetes accelerates that process, okay? So you get cataracts a little bit earlier. Thankfully, you know, technology has improved to the point where we can do cataract surgery now in about 3-4 minutes. The patient goes into the operating room in 3-4 minutes to get cataract surgery, which means the doctor will take this cataract out, put a new clean, clear, artificial lens in, and the patient will go back to where they were, you know, before they actually had the cataract, which is pretty amazing. Cataract surgery, you know, is the most common medical surgery performed in the world, not just eye surgery, medical surgery, period. But again, it's a fixable disease that we have with cataracts. Glaucoma, this is a disease involving the optic nerve. Diabetes also confers about a 2x risk of getting glaucoma, okay? But again, the main reason you guys are here is diabetic retinopathy. This is by far the most damaging and the most common form of diabetes manifestations in the eye. So does everybody know what an A1C is? Yes, okay. So most people, when they think of diabetes, they talk about, they check their blood sugar, right? And one of the issues with that is you're really just getting a single point in time. You're taking your blood, you're looking at what the blood sugar is. What it does not tell you is what your blood sugar is doing for the rest of the day, okay? So what people have come up with is actually this measure called the A1C, and what you're looking at is glucose bound to hemoglobin. And this gives you a moving average, a 3-month average of what your blood sugar is, okay? Normal A1C, they want it 5 or below, okay? And that corresponds to an average blood sugar of the high 90s. there's a very predictable way in which the hemoglobin A1C rises as your average blood sugar rises. And they use that to determine exactly what a patient's average blood sugar is. This is a very, very good way of keeping track of whether your diabetes is in check. If you're taking your morning blood sugar, fantastic, but it really doesn't give you an idea, again, of the average. The A1C taken every 3 months is really, really useful. Red blood cells have a half-life of about 4 months. So this is only a useful test every 3 months or so. It gives you a moving 3-month average of your blood sugar. The point I wanted to make with this slide as well is when you look at all of the consequences systemically of diabetes, okay, problems with the liver, problems with the brain, retinopathy is the first one to occur. This is where we see the earliest changes in a patient's body when their sugars are elevated. When you look at the A1C, when you look at the relative risk of developing any of these complications, you see the retinopathy takes off the earliest. Okay. Another thing is how common is diabetic retinopathy. This was a study done, I think it came out of like the Middle East or something like that, but it showed as you get older, your risk of having any diabetic retinopathy goes up. Just under 50% actually, as you get over 65 years of age. So it's really, really important if you have diabetes to be screened. The initial test is simply a doctor looking in your eye and maybe taking some photographs. It's very, very simple to do. All right, so what are diabetic changes in people's eyes? Okay, so it comes in a very predictable, very, very sequential pattern. Okay, the first stage that we see is mild non-proliferative diabetic retinopathy. I showed you before that photograph of a normal retina. There's the optic nerve, there's a nerve sensory retina, and there are the blood vessels in the back of the eye. Those are very clean, normal images. When we start to see patients with diabetic retinopathy, what we see is damage to the smallest vessels in the eye. Okay? What happens when blood vessels get damaged is they no longer hold blood. They no longer hold the substances of blood within their walls. They begin to leak. They dilate a little bit, and the substances in the blood vessel actually leak out, okay, into the actual neurons, into the actual neurosensory substance of the retina. What we start to see is these little microaneurysms, okay, these little spots of hemorrhage in the back of the eye. This is what it actually looks like. So when you look really, really fine and really, really close on a normal fundus image, when a doctor is looking in your eye, when they take a photograph, this is what they see. They see little dots of blood all throughout the back of the eye. Okay, these are the mildest, earliest changes. They light up on the fluorescein. One of the reasons we like to do the fluorescein is it gives us a much higher contrast view of what the retina looks like. And this is what mild non-proliferative diabetic retinopathy looks like. You start to see the capillaries don't really look normal, and you start to see these little microaneurysms in the back of the eye all throughout. Okay? A microaneurysm, what that essentially is when the blood vessel gets weakened from being exposed to high levels of sugar, the blood vessel no longer maintains a caliber, and focal areas of the blood vessel balloon up. It's called a microaneurysm. Okay? Those areas are very prone to leaking. Moderate diabetic retinopathy, you see further changes. So you have these small little blood vessels in the back of the eye, and you start to get little bleeds in the back. Okay? That's what we call moderate diabetic retinopathy. That progresses very predictably after mild diabetic retinopathy. If you control your sugar, if you come to an eye doctor and you have mild non-proliferative diabetic retinopathy and your sugar has been sky high, if you control your sugar, you will not progress to this level of disease. Those changes often will regress, or at least remain stable. Yeah?
How long does it take before it gets to that stage?
Depends on your sugar is the thought. Most patients will have some changes by years 5 and 10. Almost all patients will have changes after having this disease by years 15 and 20. It's very rare that we see patients who've had diabetes for more than 10 years that have no changes. If they do, it usually means their sugar has been very well controlled. Okay, it's extremely rare.
Does it ever become necrotic?
Does it ever become what?
Necrotic.
It does. We'll get to that in a second. Yeah, again, that's along the spectrum. But yeah, good question. So in terms of moderate diabetic retinopathy, not only do you see little bleeds in the back of the eye, the fat component, what we call exudate or lipid, your blood actually transports a lot of different things, and one of the things it transports is fat. That component also begins to leak out of the eye. So you see this little collection of fluid as well as fat coming out of the eye as well. This is one of the other things you see as the blood vessels become more and more damaged. So you can see when you do the fluorescent angiogram, that dye test again, and you take these photographs, you can see there are areas now that are black. Okay, these areas in the center here are no longer getting enough blood flow. Okay, the blood vessels in those areas have become so damaged that parts of your retina are not actually getting any blood. Okay, that's called capillary drop, and you start to see that more extensively in moderate diabetic retinopathy. So the other thing you see more of these microaneurysms, these little spots that are all lit up here, much more extensive than you saw in mild non-proliferative diabetic retinopathy. The next stage, of course, is severe. Mild, moderate, severe retinopathy, right? So in severe retinopathy, you see much more extensive bleeding in the back of the eye, much more exudate. The veins and the arteries now also look very, very tortuous. They're no longer kind of nice and straight. You start to kind of oscillate a little bit. And you start to see all these advanced changes in the back of the eye as well. More bleeding, some scarring that you see here, as well as more exudate. Severe retinopathy, consequently, and correspondingly, has also we're seeing changes on the fluorescent angiogram. Again, much more extensive capillary dropout, areas that are not getting any blood flow, and again, you see many more microaneurysms and changes in the blood vessel walls. Okay. Macular edema is a occurrence that can happen at any point in time, at any stage of those stages, mild, moderate, or severe. You can get this. So what we see in macular edema is, again, these blood vessels become damaged to the point where they not only exudate, they not only have little areas of bleeding, they actually start to leak fluid. They start to leak fluid at a rate that your body cannot absorb it fast enough. Okay, when that happens, instead of having these nice little areas of retina which are nice and thin, you get these swollen areas of retina. When that swelling occurs in the very central portion of your retina, the very central portion of your macula, you begin to become symptomatic. You start to see your vision as being blurry. Okay, and that usually this is the most common cause of vision loss in patients with diabetes. They start to get swelling in the back of your eye. If you catch it early and you treat it early, generally the results are very, very good. If you leave it long enough, and that varies for each patient, how long to leave it, one, there's permanent damage to the retina, and two, it becomes very, very difficult to actually resolve this. Even with the most advanced drugs that we have, it can be very challenging to get rid of all of this edema, okay, and have a patient get their vision back. So it's very important if you have these changes to be aggressive and take care of it early. Proliferative retinopathy. So all the stages I mentioned before, mild, moderate, or severe, generally don't require treatment. In many cases, the patients are asymptomatic at these stages. The exception is the small percentage of patients who have mild, moderate, or severe retinopathy, but have that macular edema, that have that swelling. Those are the only patients who are symptomatic at those points. Once you get to the proliferative stage, we have to treat you. Okay, that's the general rule. Proliferative diabetic retinopathy indicates a level of disease which is so advanced that the body is trying to correct that lack of blood flow by growing new blood vessels. So proliferative refers to new blood vessel growth. Proliferate growth, blood vessels are now, new blood vessels are growing in the back of your eye. And that would seem to be a really good response that your body has. Oh, there's a lack of blood flow to one of the organs, the body's going to produce more blood vessels, that's a good thing, right? The problem is these blood vessels are problematic. They don't actually do what they're supposed to do, which is provide blood flow to the retina. All they do is really cause problems as far as we know. You can actually see these little fronds of blood vessels, this web of blood vessels growing in the back of the eye. A little bit closer view of it, high magnification. They not only grow the nerve, they grow throughout the different parts of the retina. This is called neovascularization. When we see this, we know the patient needs treatment. The equivalent fluorescent angiogram of this shows these large fronds of very, very obvious blood vessels growing in the back of the eye. You can see the lack of blood flow in the area just surrounding these black areas. Okay, the capillary non-perfusion eventually gives rise to proliferative retinopathy. Okay. We'll get to that in a second, yes. Yeah, no, absolutely, good question. Okay, so yeah, you have some experience with this, right? So proliferative retinopathy, again, you can see it throughout the entire posterior portion of the retina, and again, if you treat this early, you still have a chance of seeing well. You still have a chance of recovering from this. All right, so what are the complications when we see proliferative retinopathy? What are we trying to prevent the patient from having, and what are they subject to without treatment? So one is a vitreous hemorrhage, the second is a traction retinal detachment, the last is neovascular glaucoma. Okay, we go through these. I don't expect you to obviously know the terminology, but you'll have an idea of what's going on from some of the pictures. So vitreous hemorrhage occurs when these blood vessels, again, these are not normal blood vessels, they're extremely abnormal. They do nothing except bleed and, again, cause these other complications like traction retinal detachment. So when you get these little friable blood vessels which are growing, they have a tendency to burst, okay, and release blood. And I told you before that the eye is generally filled with a clear fluid called the vitreous, and we need it clear because that's the only way light can get to the back of your eye, right? So when you have a vitreous hemorrhage, one of these blood vessels bursts, it fills the middle portion of your eye, which is supposed to be clear, with red blood. So what patients see is a cloud of red in their vision. And oftentimes the vision drops dramatically. They can't even read the large letter on the surface. During the eye, the big E that people come in and read on the eye chart, they can't even read that. The vision has dropped to a significant level. This is what it actually looks like when we look in the back of the eye. These are some of these new blood vessels growing. And this one has sprung a leak. It's created this little boat-shaped hemorrhage here. And eventually, like shaking a snow globe, the red blood cells in this area disperse. They go throughout your vitreous. And as you can imagine, the person with this level of vitreous hemorrhage can't really see. Okay, their vision is actually quite compromised. They may have a little bit of island of vision here, but the majority of their posterior vision is actually gone. okay, that's blocked off by this blood. That's complication number one. These blood vessels bleed. The next thing that these blood vessels do is they cause traction and they cause retinal detachments. As these blood vessels grow, scar tissue grows with them. Okay, you start to see this extensive white fibrous tissue growing with these blood vessels. As you can imagine, if you have a curved surface, which is the back of your eye, and you have a straight layer of scar tissue growing over it, the tendency is for that scar tissue to contract and pull the retina off the back wall of the eye. This is called a tractional retinal detachment. This is a very advanced change with diabetes and very challenging to actually fix. As you can see, it starts out at this relatively treatable area of scar tissue, but over time, it forms a denser, more extensive fibrous tissue. This is an example of what's called a complete tractional retinal detachment, a complex retinal detachment, where you see fibrous tissue and it's pulled up the entire retina off the back surface of the eye. This is very difficult, if not impossible, to fix. It's very rare for a patient to regain vision once the retina gets to this portion. Even if you go in and you completely remove the scar tissue and flatten the retina out, the tissue is so damaged that you can't really gain any vision back. It's analogous to chopping off your arm and reattaching it. If you do it relatively early, maybe you'll get some function back, maybe, right? With the retina, if it gets to this point, chances are there's so much damage that even if you reattach the retina, it's very difficult for a patient to get any functional vision back. When you're treating a patient at this point in time, the goal at this point is really not to have them regain 20/20 vision. It's to have them gain some vision back. But more importantly, when the retina remains detached for a long period of time, the eye begins to shrivel up and die. Okay, you've probably seen people with these scarred over white eyes. This is called phthisis bulbi. It's very advanced changes. So the goal at this point is not only to try and gain some vision back, the primary goal is usually to preserve the eye, to make sure the eye doesn't scar off and die. Okay? Again, you want to obviously be treated long before you get to this point. In terms of neovascular glaucoma, so those two changes before, the bleeding in the back of the eye, vitreous hemorrhage, as well as the traction retinal detachment, those are changes we see and we can treat relatively well if we catch it early enough. The third change is neovascular glaucoma. So I mentioned before, glaucoma is a disease where effectively you have damage to the optic nerve and it's associated with elevated pressure in the eye. When we look at the eye again, the structure that we're talking about here is the optic nerve. And there's a really peculiar thing about the eye. The vitreous cavity, which is this back wall, which is filled with that clear gel, is one portion of the eye. There's another little chamber in the front called the anterior chamber, which is filled with a fluid called aqueous fluid. It's a liquid, it's not a gel. And your eye has this weird sort of physiology where it produces liquid and it also drains liquid. So it produces liquid right behind the colored portion of your eye. That liquid goes around the colored portion of your eye, goes around your iris, and it goes and it drains through a little trabecular meshwork, a little drainage system in the angle of your eye. Okay, and that physiology is really, really important. If it gets blocked off, there's a mismatch between the amount of fluid you produce and the amount of fluid you drain, and that leads to changes in pressure in your eye. When you have glaucoma, there's an imbalance. The fluid in your eye is not draining as well as your eye is producing fluid. So what happens to the pressure? It goes up. Okay. The same thing can happen. When you have neovascular glaucoma, what happens is you get these growth of blood vessels. Again, you get them in the back of the eye. That's the proliferative changes we saw in the fundus photographs of the retina. But you also get these extensive blood vessels which can grow on the front of your eye. When they grow in this area, they have a tendency to block off that drainage system right in there. When that happens, the pressure in the eye can go sky high. Okay, it's not uncommon. When a patient comes in with regular, non-diabetic related glaucoma, they'll come in with a pressure of 35, 40. Normal pressure is between 5 and 21. They'll come in with a pressure a little bit elevated. When they come in with this, it's not uncommon for them to come in with a pressure of 50, 60, 70, and sometimes it's so high we can't even read with the turn. Obviously, we want to catch it before it gets to this point. When your pressure is that high in the eye, the optic nerve gets beaten up. Okay, it's very difficult for blood to flow normally in an eye with pressure that high. And as you can imagine, lack of blood flow to the optic nerve leads to irreparable damage to the vision. Okay. Sometimes these blood vessels can also bleed and you can get a layer of blood forming in the anterior chamber. This is called hyphema, and we see this as well, okay, in patients who have neovascular glaucoma. How do we treat this? So this goes to your question before about the injection. There's really three ways to treat patients who have diabetic retinopathy requiring treatment. The first is injections. We give them a medication, a shot into the white portion of the eye. Okay, that's a relatively, it sounds horrible, yeah, and I can see you making a face, but believe it or not, we numb the eye in such a way that it doesn't hurt. Okay. The second way we have is laser treatment, and the last thing we do is surgery if we absolutely have to. Okay, so intravitreal injections into the eye have really revolutionized the field. These were FDA-approved drugs. They were initially cancer drugs in the field of gynecologic cancer that were approved, I think, in the 80s or 90s, but they were FDA-approved for use in the eye really about 15, 16 years ago, okay? And they really revolutionized our treatment of not only this disease, but other diseases like macular degeneration and even vascular changes that we see in premature babies. But anyway, in terms of what we do, in terms of the procedure, effectively the patient is sitting in clinic. The whole thing takes a few minutes to do this. The patient sits back, we numb up the surface of their eye with a little bit of lidocaine, the same medication you get at the dentist's office. Then we inject them into the white part of the eye. The whole procedure takes literally less than a second. Come in, get the injection, you go home. Okay, the medication itself has the effect of stabilizing the blood vessels in the back of the eye. When you have new blood vessel growth, it can even cause regression of those blood vessels. It's fantastic. The downside of the intravitreal injections is that it's temporary. Like any medication that you take in your body, whether it's Tylenol, whether it's insulin, there's a half-life. Your body will excrete the drug over time. And the same thing happens with these intravitreal injections. So in general, it's not a one-time thing. Most patients who develop years and decades of developing these ocular changes from diabetes need more than one shot. They need at least a few months of treatment before their eye starts to return to kind of a stable place. That's one treatment, the intravitreal injections. An older treatment for diabetes is laser therapy. And what we simply do is we have a patient in clinic. The laser is attached to a microscope on in some of the equipment in the clinic. The patient sits down, they kind of maintain their face in the microscope, and we apply laser to the back of their eye. Usually we use a contact lens. Most patients, when we're applying laser to the eye, are a little bit worried that they're going to blink or they're going to move. But the contact lens that we use is very, very helpful in maintaining their eyelids open and giving us a great view of the retina. The laser is really used in several different ways. But one of the ways we use to treat it is when a patient has proliferative diabetic retinopathy, it has this growth of new blood vessels. We apply it to those areas that are dying, those areas of black that you saw in the fluorescent angiogram, which aren't getting enough blood. And this has the result of causing those new blood vessels to regress. The benefit of the laser over the injection is that it's more durable. Once you do laser, it's generally permanent. Once you do the injection, I told you, your body will get rid of it, you'll need another injection. If you apply enough laser, in general, the patient does not need laser for the rest of their life, okay, which is very, very helpful. So laser is one way to augment the treatment with the injection. It actually does. So the damage is actually already done. You have this dying tissue there. We can't go in and remove it, so what we do is we apply a laser. The thought is when you have portions of your retina which are not getting enough blood flow, they're releasing a signal into your eye saying, grow more blood vessels. That's a problematic signal, right? Because those new blood vessels that grow are an issue. They cause those three complications that were mentioned before. So if you apply laser to those areas, they no longer produce that signal, and therefore the growth of blood vessels is kind of abetted, and additionally those blood vessels regress. So that's very helpful, okay? It's arrested, not abetted, rather. The growth of blood vessels is actually stopped. So that's the laser treatment that we use in the eye. And this is an example of what it might actually look like. This is kind of an illustration of it, and this is what it looks like. This is a laser that has been treated extensively with, this is a retina that's been treated extensively with laser, okay? So surgery. So the final step is once we get to a certain point, for example, when the eye fills with blood and a vitreous hemorrhage, when the patient has a diabetic traction retinal detachment, we get to the surgical portion, okay? The surgery is done, the first question they ask you is, are you going to take the eye out of the socket and do it on the table and put it back in? And the answer is no. The surgery is done with the, in the actual patient's socket, okay? The eye is not removed from the actual body. So what we do with the instruments is we make these 3 small incisions. Each one is about 1/3 to 1/2 of a millimeter in terms of the length of the incision. And we make 3 of them on the surface of the eye. We're looking through the patient's pupil into the back of the eye, and we're doing surgery. There are various instruments which we put in, and the first step, obviously, is removing that gel. You can't really operate with that gel in your eye, so we remove it. That's called a vitrectomy. You no doubt will hear this term if you ever have diabetic eye surgery. The instruments that we use are very fine, and we use these instruments to really peel away scar tissue, okay? Once you get a diabetic traction retinal detachment, the goal is to remove all the traction, is to remove all of that scar tissue and all those new vessels from the black of the eye. And again, we have very specialized instruments for doing this, and the technology is really advanced. Surgeries that used to take 2 or 3 hours, you can now do in about 30 minutes or so, right? They're fairly fast. This is an example, an intraoperative photograph of what that actually looks like. This is not too extensive an amount of scar tissue, but you can see the instruments are used to kind of break up the scar tissue and carefully peel them off the back of the eye. Actually, that's the last one. One thing I would say is when it gets to a certain point, it becomes really challenging to peel the scar tissue off. Sure, I showed you before where the entire retina was detached. Those surgeries, even with the technology that we have, those can often take several hours, right? We're essentially peeling off cement from really wet, delicate tissue paper. So ideally the goal, Okay, even with all the technology we have, those are really quite challenging surgeries. The goal is to catch your diabetic retinopathy early. If you get laser, if you get injections, if you're consistent with your follow-up, you should never get to the point where you need eye surgery. Okay, and that's the whole goal. A lot of this is really about raising awareness. We have great treatment for a lot of diseases, including diabetic retinopathy, but you have to catch it early. That's really the key. Okay, so that's it for my talk in terms of the formal presentation. If you guys have any questions, I'm happy to address them. Yes?
What if, in the back of your eye, if a little piece starts to tear, what is that called and how could it be treated?
With related to diabetes? Or just in general? Right, so you can get those tears as a consequence of getting older as well. That vitreous gel that I mentioned before, as you get older, it exerts traction, it begins to pull on the retina, okay? If it pulls and the vitreous gel comes off of the retina clean, that's normal aging. People see floaters for a few months and then it goes away. But on occasion, that vitreous gel can pull so hard that it creates a little tear in the retina, a little tear in the wallpaper. Then what can happen is that vitreous gel can get into that tear under the wallpaper and pull the wallpaper off. That's called a retinal detachment, or retinoschisis retinal detachment. That can happen as a consequence of aging, whether you have diabetes or not. It usually happens between ages 50 and 70, that process.
What have we done?
Surgery, yeah, so it's a type of retinal detachment surgery that we do to fix that as well. Again, vitrectomy is one way to do it. Another thing that people do is they put a little band around the eye called a skull buckle, you may have heard of. But those are the two main ways to fix that. That can also happen in diabetes. When you get enough scar tissue, sometimes the scar tissue can pull extensively to the point where it creates a little rip in the retina as well. Similarly, usually at that point, a patient would need surgery. Other questions? What time is it? All right, well, that's about 30 minutes of this. Thank you, really appreciate it, okay? So yeah, my information is in the front. If you guys have any questions, by all means, please reach out. We're happy to see any of you.